The first specific application we're going to talk about for electrical stim is using electrical stim for muscle contraction. So we're going to be doing neuromuscular re-education or muscle strengthening, specifically using electrical stim. So because the normal function of muscle is the motor neurons come down and they meet the muscle at the neuromuscular junction and elicit a muscular contraction, we can use electrical stim to do it artificially while the brain's on vacation or there's been an injury, something's happened. We can use that for muscle contractions. So we're going to talk about muscle contractions in innervated muscle and the clinical applications for that, and then muscle contractions in denervated muscle, and then the parameters, of course, and documentation is super simple, just like it is for the other areas of eStim, and we'll talk a little bit about that. And we will take up that discussion again in lab as well, and we will be writing SOAP notes. So this is just a review from the last lecture. In order to stimulate the action potentials in nerves, we look at our strength duration curve, and we've got the A beta sensory nerves with a pulse duration of pretty low, maybe 10 to 100 for the sensory nerve stimulation. Motor nerves start in maybe at about 100 to 350. And as you can see, that A delta sharp pain nerve is coming in there around the 2-300 range. So when we're getting into those higher pulse durations with muscle strengthening, we also might be stimulating some pain. So I think I said in the last lecture, we were doing some training on a new functional electrical stim bike we got at the clinic where I work, and I was the guinea pig. I was hooked up to it, and to get a good, what I felt like a good muscle contraction, good muscle tetany is what I wanted. We were up at about 250 for pulse duration, and it was pretty uncomfortable. I mean, and we're talking big muscles, quads, hamstrings, glutes, and so we were at those longer pulse durations because we wanted to get motor, and they're bigger muscles. So it didn't hurt. I mean, I guess it depends on what your definition of pain is, but it was pretty uncomfortable. And then you're not going to be getting the C fibers in the denervated muscles until we get to much, much longer pulse durations. And we'll talk about that. So the action potential is propagated along motor nerves. It crosses the neuromuscular junction and the muscle contracts. So when we have a normal physiologically initiated contraction, usually the slow twitch type 1 muscles contract first. We talked about this a little bit in kinesiology. We start with a low contraction force and a slow speed of contraction. Because we are not going to fatigue quickly, we're going to conserve our energy, and we're going to recruit muscle as little as we need to do the job. So the muscles don't atrophy as much because we're getting that normal stimulation, and the recruitment is asynchronous, meaning we can recruit individual muscles. Our nervous system has the capacity to decide which muscles they're going to recruit for a particular motion. So with an electrically stimulated contraction, it hits the fast twitch type 2 first. High contraction force, a fast speed of contraction. So we'll try it in lab, and when you get that action potential, you get that speed of contraction, it's like bam, the muscle contracts. It fatigues quickly, and it atrophies quickly, and it's usually synchronous recruitment, meaning every muscle in the electrical field is going to contract. It's not going to be specific ones necessarily. So if it's within that electrical field, you're going to get a muscle contraction synchronously with all the other muscles in the field. So electrical stim strengthens muscles the same way physiological stimulation by the overload principle. So if we increase the pulse duration, the amplitude, the electrode size, we add external resistance, a higher load, a higher force, gets greater contraction and greater strengthening. So the way we're strengthening the muscle is exactly the same as with a physiological contraction. We're just getting there on a different road. So with specificity, the contractions specifically strengthen the fibers that contract, right? So electrical stim has more effect on type 2 fast twitch muscle fibers than on type 1. And disuse atrophy after an injury or something like that is primarily type 2 fibers. That's why electrical stim is often a good clinical treatment for disuse type of atrophy. So with orthopedic conditions, increasing strength after surgery, after ACL construction or total knee arthroplasty, sometimes non-surgical management of knee conditions like osteoarthritis, rheumatoid arthritis, patellofemoral syndrome. Remember in kinesiology when we were talking about patellofemoral syndrome, and one of the intrinsic causes can be a weak VMO. We could use electrical stim to strengthen specifically that VMO. With sort of the current trend in total knee arthroplasty is to use a minimal amount of electrical modalities because we have found that people who are actively contracting their muscles get their function back sooner than people who are doing it passively, and this is passive. I mean, we do encourage the patient to try to do a contraction at the same time the electrical stim kicks in, but it's still a passive treatment. So with neurological disorders, a lot of times you have an intact peripheral nerve, but central nervous system damage, like a spinal cord injury, stroke, MS, traumatic brain injury, or CP. And so even though the muscle and the peripheral nerves are intact, you're not getting the stimulus from the upper motor neuron or the lower motor neuron, depending on where your injury is. So by doing electrical stim for muscle contractions, this is a really good intervention for people with neurological disorders because they can't do it on their own. Someone with an orthopedic disorder, they can do it on their own, but a neurological disorder, they can't. And it's an excellent way to build strength with people with neurological disorders. You can also integrate performance with functional activities, such as in functional electrical stim, and we will talk a little bit about that. So for spinal cord injury, a lot of times you get disuse muscle atrophy because you don't have the upper motor neuron stimulation because there's a disconnect somewhere in the spinal cord where you had that spinal cord injury. So you're not going to correct someone's spinal cord injury with electrical muscle stim, but you can improve circulation. You can contract the muscle to assist with locomotion if it's possible for that person. You can contract upper extremity muscles to assist with hand grasp, respiration, conditioning, and bowel and bladder voiding. So huge difference with someone with SCI. A lot of times we're just trying to get them to their maximum effectiveness. We're not going to cure the problem. We're not going to fix it entirely, but we can get them to their maximum effectiveness. So when we're doing electrical stim, if we're doing it for functional activities, the muscle has to be able to contract with sufficient force in order to carry out activity, whatever that is, whether it's a functional electrical stim bike or a hand grasp activity or respiration. That's always nice. We don't want the E-stim to be painful, so sometimes people with incomplete spinal cord injuries, they have a lot of sensation but no motor, and so it might be too painful for them. So we want something that can be controlled and repeated and is acceptable to the patient, so then they can continue it and increase their strength. So it has to be tolerable. Same thing with people for stroke. If you can stimulate their affected extremities, it says lower extremity, but it goes for upper extremity as well, it can result in improved gait, increased ankle dorsiflexion torque, reduced agonist-antagonist co-contraction. So those are those synergistic movements that you get with stroke, and we'll talk way more about that in the winter and spring quarter. It also increases their probability of, if they're not already home, returning home and being more independent at home and needing less assistance. So that's a huge big deal. So a lot of times we use the neuromuscular electrical stim. Functional electrical stim is also really useful for people with strokes. Antagonistic contraction to reduce agonist spasticity. So if you have someone that's got a lot of flexor synergy in their upper extremity, you're going to stim the extensor muscles to get them out of that spasticity region. You can do an agonist contraction to increase agonist strength and control. So electrical stim is a really effective modality for stroke patients. And in the clinic where I work, we don't use stim a lot for orthopedic patients because we are sort of on board with the active motion is better. But boy, oh boy, we sure use it for stroke people, and we use it for people with SCI. So awesome use of electrical stim. So this is a picture of someone getting hooked up to a functional electrical stim bike. There's a video in the module you can watch that's associated with this. We have a lot of people, a lot of the functional electrical stim bikes, either they're in a facility, most of them though are in people's homes. People get coverage, insurance coverage, or another way to pay for getting an electrical stim bike in their home to keep them as functional as possible. And in the facility where I work, we have a functional electrical stim bike that has lower and upper extremity attachments, and we use them in therapy, and we also use them in, if we have someone, we start them on an independent program where they can come into an independent gym session in our clinic and use the functional electrical stim bike on a regular basis, and so that can be a really big thing for people. So with sports medicine and performance, sometimes people will use neuromuscular electrical stim to add it to strength training to enhance strength gains. It may or may not enhance functional performance because there's a lot more to sports performance than strength. So you can Russian stim was originally developed with for use with athletes to increase their strength and enhance their strength gains. So it's not a substitute for sport-specific training, of course, because it doesn't train the muscle in those sport-specific activities. It just helps with your strength gains. So other things that it's possibly used for: dysphagia, stimming the muscles of swallowing, urinary incontinence or pelvic floor dysfunction, if you work in a clinic that has women's health, promoting circulation and reducing risk of DVT formation. So all those are good things. So when you have denervated muscles, you are not going to make improvements that persist after the stimulation is stopped. So if you have if you have a complete spinal cord injury, or if you have any kind of situation where the muscle is denervated, you are not going to make any gains. What you are going to do is you're going to increase circulation. You're going to prevent deterioration of the muscles, and really, so we're trying to prevent deterioration more than we're trying to improve from where they are, because you can get a muscle contraction while you're doing it, but the improvements don't persist after the stim is stopped. So huge pulse duration, greater than 10 milliseconds. So normally when we're talking pulse durations for muscle stim for innervated muscles, we're talking 200 to 350 microseconds for pulse durations. Now we're talking 10 milliseconds, so an order of magnitude longer. And it uses continuous direct current, because basically we're just doing everything we can to get that denervated muscle to contract. And the main reason for doing it is to prevent deterioration. So whether we're doing whatever kind of muscle stim we're doing, we want to have one electrode over a motor point on the muscle, and we'll figure out where those are in lab. And the other electrode over the stimulated muscle aligned to parallel to the muscle fiber direction. And the electrodes should be at least 2 inches apart, because if they're too close together, you're actually forming a really big electrode and you have a higher current density, and that can be painful, and you can actually cause burns with that. So in the picture, it's electrical electrodes for the quadriceps muscle. You can see it's way up there at the proximal end of the quadriceps muscle and down to the distal end. And you can have the electrodes closer together depending on where your best motor points are. You want to keep the joint in mid-range. So, of course, we know if you're stimming the quads, you're going to get knee extension, right? So we want to keep the joint not fully flexed, not fully extended. It's in mid-range, so you have some room to move. And so you can have an isometric or an isotonic contraction. So an isometric contraction, you can tell them, well, just squeeze your quads for everything you're worth while you feel that E-stim on, and then when it goes off, relax. Isotonic, you can have them do an active knee extension, if it's possible for the patient, while the stim is on. So amplitude, we want a muscle contraction that's greater than or equal to 10 to 50% of the maximum voluntary isometric contraction of the uninjured limb. So how do you figure that out, right? The way you figure it out is you palpate. You're going to palpate the muscle while you're doing E-stim. You want to feel a nice, strong muscle contraction. So you have to work within a pulse duration of 150 to 350 microseconds for those motor nerves. You have to find a pulse duration and amplitude combination that is comfortable enough. You can turn the amplitude up high enough the patient can stand it to get a nice, strong muscle contraction. So we're going to try it in lab, and it's going to be fun. So usually our frequency, we're going to be at 20 to 30 pulses per second for small muscles, 35 to 50 pulses per second for larger muscles. Sometimes, if you're really working on muscle strengthening, you're going to go higher, but it also increases fatigue. So interestingly enough, a lot of the muscle stim applications, the main ones that we're going to use in lab and we're going to try are VMS, variable muscle stim, which is a pulsatile application, and Russian stim, which is an alternating current application. So you might not, for most machines, you might not be able to adjust the frequency for muscle stim. You can adjust the amplitude and the pulse duration, and the frequency is going to be set based on what you set for those. With the next thing we're going to talk about after this lecture is E-stim for pain control, and then usually you can adjust the frequency and the amplitude, but the pulse duration is set on the machine. So there's some things that you can adjust and some things that you can't, and we're going to play with them in lab and see what the effects are. So usually with muscle stim, you want on-off times to be, depending on how many you kind of have to figure out how long are you going to do it, how many contractions do you want, and how much rest time in between. So usually you're going to have it be on for 6 to 10 seconds and off for 50 to 120 seconds. Actually, I usually do 10-30 or even 10-20 for a stronger person, because we're going to fatigue. We're not resting that long. So I've been working with a guy who had some foot drop after a total knee replacement. His tibialis anterior was affected, and we've been doing neuromuscular stim on-off times of I've been doing 10-30 with him. And so if you think about it, 10-30, that's 40 seconds for each contraction. 10 seconds on, 30 seconds off. And so in a 10-minute session, we're going to get less than 10 contractions. So think about how many muscle contractions you get in a session. So in a 15-minute session, we're going to get between 10 and 15 contractions. So in order to strengthen muscle, we want to reach failure at 10 to 12 contractions. So that kind of tells you what you want for your on-off times. Sometimes it's 1 to 5 or 1 to 3. I like 1 to 2 if you're really trying to fatigue the muscle. But ramp up, ramp down times are going to be 1 to 4 seconds. Usually on average they're about 2. If you have a lot of spasticity, you might go less. The ramp time is nice because it sort of gradually builds up the stim, and it allows for a graded response with the muscles, which is more physiologically normal. And it's also not a big jolt. Yikes. It lets you ease into the muscle contraction. So it's a little more comfortable to have ramp up and ramp down times.